Hey guys, Don here. Welcome to Podiatry Practice Mastery. I'm going to go over the $1,000,000 minute. So these are the things that I go over that would help, things that help me get to the $1,000,000 mark and beyond. So I'm still struggling a little bit with my new medical record of writing down all the patient information. I think it's because I'm more preoccupied with my charting right now than I am like documenting these things. A lot of times just want to get done. It used to be a little bit easier. The printout of the patient list was a little bit easier. The newer one doesn't leave me enough room, so I'm trying a different one. So I'll go over the main ones here. So the first one was a 53-year-old female. They got a Lamisil booster. They originally had tinnitus. Things are doing better, so kind of medication management, that's continuing with this medication. Next was a 45-year-old man. He got the Pelto special, so that night splint foam rolling morning stretch due to plantar fasciitis. And we're starting a shockwave number 1 out of 3. The reason I'm doing less versus the sixth, probably because I think I prejudged this patient, frankly. And also I think he only had pain for a couple of months, and so that's why I put it down to 3. I'm trying to do more 6, but I'm still finding that my tendency, if they haven't had it longer, I'm starting with a lower number, and then I can do more later. I also did an ultrasound same day. I think there's a big key with doing shockwave and doing it the same day and along with the ultrasound. I find that when I'm doing ultrasound the same day, I can show them the anatomy on one side or the other, and that's really my number one thing that helps explain to patients that the anatomy is different. That's the reason for the shockwave. And then if I can start the shockwave the exact same day, it really speeds things up with patients' adherence, because they already start the process and then they'll continue on with the other treatments. It makes it much more efficient for them. I think in the past I used to always I was too busy and I was kind of scheduling things out. I just find if I can take the 5 to 7 minutes and just do it that day, it's much better to start treatment same day when you're doing shockwave. So just so everyone knows, when I talk shockwave, we have 2 radial machines, and then we have a focused and a soft wave. So we have a radial in both offices, and then one of our offices is focused and one of them has a soft wave, and we kind of use them interchangeably, and my results seem to be interchangeable at this point, just so you guys know. Next was a 73-year-old female, kind of had a bad ankle sprain, and I put them in an ankle brace, and I'm going to follow up in about 3 weeks with possible ultrasound to look at the ligaments. I didn't do the ligaments the first day, just because of all the swelling, and I was going to do it at the follow-up one. It might be more of a confidence level on my end of things, looking at the lateral ankle ligaments, and maybe I should be doing it the first visit for these patients, but I wasn't doing the ultrasound. If anyone's really good at ultrasound looking at the ligaments, let me know. If you do it the first visit, I'd like to know what other people are doing. Next was this is that anterior calcaneal kind of beak fracture that we're doing. We're number 5 out of 6 for this. Female, she's feeling better, kind of getting out of her cam boot. I'm hoping that's healing in there. I'm going to do number 6 next time, and I'll get an x-ray at that time. Next was a 62-year-old. This is a woman that came in. She had previously had a kind of a midfoot fusion, first, second, and third metcuneiform joints, and that was about 4 years ago. That surgery looks solid, and she is here now. She had an ankle sprain, and she fractured her fibula, so I put her in her tall cam boot. She is a very active pickleball player. These pickleball, I tend to find that they're really active and they want to do anything they can to get better faster. And so for her, I am doing 4 sessions of shockwave, both to get down the swelling, but also to help kind of heal things a little bit faster with the focused shockwave. So we're going to be doing that for her. Now, this would be kind of an MVP, most valuable patient, because of the shockwave for this patient, because you get the non-operative fracture treatment, you get the office visit, you get the cam boot, and then you get the 4 sessions of shockwave. Who are the ones that are wanting to do shockwave for fractures? It's usually the ones that are in a hurry to get back to activity. Now, can the shockwave heal the bone faster? It might heal it a little bit faster, but what the research shows is that return to play or return to activity is speeded up. And for her, this is what's important. Because we know it's longer than the 6 to 8 weeks that it takes to heal this. The return to activity, because of the tissue around it as well. So I'm going to be treating the tissue around it with the radial and then the fracture site itself. And then I think you might speed it up maybe 20% with the fracture healing. But the return to activity will be increased. That's anyway the way I understand it. I'd like to know what other people think about this. Shoot me an email, don@podiatrypracticemastery.com, if you have any comments on these things, or if you guys practice a little bit different, and we'll share it with other people. Next was this was a patient that had fourth and fifth digit maceration. I want to talk through this one. So fourth and fifth digit maceration, kind of have toes that were tight, been that way for years, kind of has a bunion, Taylor's bunion, that are pushing the toes together. So the takeaway to make this like kind of more of a larger check is when she came in, there was a cellulitis, so I put her on antibiotic. There was an ulcer, so I debrided the ulcer. So it was ulcer debridement the first time. Had lamb's wool betadine dried out. Second visit today, wearing kind of wider shoes. Maceration is getting better, and I talked to her about possibly doing an arthroplasty in the future because the bones are kind of rubbing against each other. So I think the mistakes I've made in the past is when there was a maceration in there, I just kind of curetted some of the maceration out, but I did not debride the ulcer. So in this case, debriding the ulcer really kind of brings up the level of the visit, especially with the antibiotics. And then instead of just like, okay, see maceration, or see, a lot of these ulcers, I think we're seeing the ulcers, we're debriding the ulcers, but we're maybe treating them as calluses or not billing fully. So I think this is something just to keep in mind. And I think a lot of times, frankly, it's because the documentation is challenging. And we're doing it because we're lazy, because it's easier just to trim a callus, and even though it is an ulcer, but the documentation for the ulcer is a little bit more challenging. So just something to kind of think about. Next was a 13-year-old. I did an IND for an ingrown toenail, no follow-up. Next was a 35-year-old. This was this fibular sesamoidectomy. She had a little bit of sutures, some vicryls that were kind of coming out of the incision, so I removed those. She's still kind of recovering from that. Next was a 55-year-old that had partial nail avulsion and debrided a couple of the nails. Next was a 69-year-old female with posterior tibial tendinitis. So this is kind of a challenging one. She has a lot of ankle arthritis, midfoot arthritis, but what's hurting her is the posterior tibial tendon, and she thought she had gout. So she had kind of a slightly elevated uric acid, and she was treated kind of with gout with like a Medrol dose pack. But where her pain really is the medial ankle towards the tendons, like the posterior tibial tendon, maybe the flexor digitorum. I did an ultrasound today. I saw some thickening and effusion around those tendons, and she's going to be going on a vacation. So I did a little bit of cortisone in that area, and I talked to her about when she gets back from vacation to start shockwave. So I'm going to see her back in about 4 to 6 weeks. I tend to, if I do cortisone, I don't do shockwave for 4 to 6 weeks to get that out of their system, and then I'll start some shockwave because, she has kind of a pes planovalgus type of a foot, and versus like a surgical repair, I think getting her with a shockwave with that tendon and then getting her into some type of an AFO, if she's willing to do that, either AFO or an orthotic. I find a lot of times females are quite vain and are not wanting to wear the AFOs. They do a little bit better with more of a stability orthotic. Next was a 72-year-old. This was a female that she had a cyst drained twice, and she had a bilateral bunion. So she said there was a ganglion over the bunion. It didn't really come back. She said she didn't want to get x-rays. So this was one, I don't know if I was just busy or what. Usually patients come in, a lot of times they tell my staff they don't want x-rays. I can usually have them get x-rays when I talk to them, explaining that to them. I sometimes find when patients have a strong accent, I have a hard time being more kind of authoritative with them or telling them what they need because of the language barrier. I find sometimes this language barrier can be a challenge. And so this patient, I have a lot of Albanian patients, and I just find it hard with the accent. Maybe I'm afraid they're not understanding me why they need the x-rays, but she does need x-rays. She just did not want to do them yesterday, and then I get struggle with the accent, and I just kind of go on and okay, forget about it. But probably would have been better to get the x-rays, at least some baseline x-rays for her. She said she had them somewhere else. That's why she didn't want to repeat them, and she was worried more about the quote-unquote cyst. But she does know me from the hospital. She works at the hospital, and she's wanting to consider bunion surgery, but maybe just not today. So I did not get the x-rays today. Probably for practice management would have been better to get those x-rays. And she did bring a friend with her that had bunions as well, so we talked to her about her friend's bunions as well. Next was an 82-year-old female. She had kind of like second and third digit hammer toes that were dorsally dislocated or contracted, and she had painful second metatarsal head and a callus down there. So I trimmed the callus, but I really said she needed more work with that second metatarsal. There was really no fat pad underneath there, so we talked to her about orthotics. I think she was a little upset. I think she might have been waiting a little bit, and this was one that was kind of a struggle. When they're waiting, and you feel bad because you're already starting behind, and they're already frustrated. So I didn't do much for her, and I felt like she wasn't too pleased. So I'm probably going to call her and make sure she's doing okay today. So these are those ones that, she came in. I didn't really help her that much. She didn't have much of a callus down there, and I actually felt guilty for charging her for the callus because I was running behind. So I'm just kind of sharing kind of the emotions that I feel throughout the day. And so for this one, I feel like I didn't do too much. I didn't feel like she was connecting with me. She was kind of like standoffish, wanted to get out of there, very curt in her responses. And then the last patient was a onycholytic nail bilaterally that this patient kind of got it snagged on something. I did trim it all the way back to where it was attached. And in a couple weeks, she'll come in for a carry flex. And I actually had another patient that came in for bilateral carry flex as well this day. So this was the day. I think the MVPs would tend to be these shockwaves that I was doing for these patients. And I feel like now that things are calming down with the new medical record, I'm able to focus more on these types of patients. Once again, I'm doing a new kind of a section in podiatry management. And the next article is going to be on how to get a new associate busy. So I'd like to know if you've had associates and if you've been successful getting them busy, what you kind of did. Because I think one of the struggles when doctors are starting out, they don't have very many patients. And how do we get them busy besides just kind of giving it time? Do you throw money at AdWords? Do you have them get out into the community? What is it that you do to get the patients busy? If you have good tips or things that don't work, let me know, okay? So I can include that in the newsletter. Shoot me an email, don@podiatrypracticemastery.com. Also, just let me know how you're liking this, if you found this beneficial. Okay, have a great day.